Here we are. Here we are. So for those of you who have been through this before, I did shorten the presentation to hit the highlights. If anyone needs to review the original pre-amendment training, I believe that is on our YouTube. So again, this is just kind of a refresher with highlighting the changes that we just made in the last amendment and giving everybody a chance to ask questions. The slide of the core staff at every site is there for your reference, which is very nice. Savannah's going to send these out after our training. So the objectives are still to, the primary objective would be the clinical efficacy and safety of the anakinra plus zinc and the GCSF compared to what our current standard medical treatment is. We're going to evaluate the use of biomarkers to assess the disease severity and treatment response, and to develop any novel endpoints to overcome the limitations or of current assessment strategies for alcoholic hepatitis. It is a phase 2B multi-center prospective randomized 3-arm double-blinded placebo-controlled clinical trial, say that 3 times fast, to assess what we just talked about with the treatment of severe alcoholic hepatitis with a MELD score greater or equal to 20. They will, all participants will receive the standard of care for treatment as described in recent guidelines endorsed by the AASLD and the ACG. It is being conducted, is it still 8 sites? Didn't know if we moved to 9, but we're all across the United States here, and they have been selected by the National Institute of Alcohol Abuse and Alcoholism, and will be supported by the DCC at Indiana University, and the biorepository is managed by the University of Massachusetts. Our endpoints will be the survival at 90 days, the changes in scores, measurement of organ dysfunction, infections and sepsis are a very big watch element for this study. Any renal dysfunction, need for care escalation, so either to ICU, being intubated, ventilator support, and we're monitoring this at all time points. Some of the study labs are the indicators of the gut permeability and survival at 30 and 180 days. So we have 387 subjects for this study, 129 in each of the 3 arms. We're anticipating that each site will enroll 49 participants over a period of 5 years. The accrual goal for 2020, I think roughly 12 participants per site is what we're kind of leaving it at this moment. So the Manual of Operations and Best Practices Guidance, this isn't referring to our coordinator Manual of Operations. This is what they have outlined in the protocol in developing best practices on the management of sepsis, use of vasopressors, albumin, ICU, mechanical ventilation, nutrition, and alcohol use disorder in patients with alcoholic hepatitis, the Surviving Sepsis Campaign, international guidelines for management of severe sepsis and septic shock, as well as the AASLD and the ACG guidelines on management of alcoholic liver disease, are the sources for the recommendations for the guidelines within this MOP. And we do recognize that all of our practice varies between sites and locations across the U.S. We're not actually trying to protocol the approach to each of these complications across the 8 sites. We're just hoping that general guidance would be a useful tool to investigators and clinical care teams to increase the general uniformity of approach to the treatment. And again, we're not mandating these by protocol or MOP, but the clinical care provided will be recorded to develop novel designs for future trials and for practice guidance and quality improvement programs. So we're not only looking at the data and the outcome of the study drugs, but we're also trying to improve how alcoholic disease is treated across, the nation and hopefully, universally across the world. We do hope that you will distribute this document among your hospital co-investigators, coordinators, and with the hospital staff to provide them with additional guidance in treating these patients. So study arms and medications, of course, after ensuring that they will meet all of the inclusion and none of the exclusion criteria, and after the informed consent has been obtained, participants will be randomized to receive one of the following interventions in addition to standard of care. Does anybody have, at this point, any questions about the 3 arms? I know at the beginning it was kind of confusing to all of us. Any in particular? If you think of any, don't ever hesitate to reach out. The one change that has been made with this amendment is that the weight for the group 3, the GCSF arm, has been changed from 60 to 80 kilograms. So it's 80 kilograms and less or greater than 80 kilograms as the division line for who either gets the 300 microgram dose or the 480 microgram dose. Here is a visual for the arms, if that is helpful. So inclusion and exclusion, we did change. So it is important to note that the study population will be comprised of men and women of all races, ethnic groups, and socioeconomic status between the ages of 21 and 65. So even though the ages of 21 and 65 aren't technically, listed in this inclusion and exclusion, it is listed in the study design. So we wanted to make sure that we pointed that out. They will be admitted to the hospital with a clinical diagnosis of alcoholic hepatitis. Alcoholic hepatitis, as defined by the NIAAA PAN Consortia for AH, is the onset of jaundice defined as a serum total bilirubin of greater than 3 milligrams a deciliter within the prior 8 weeks, so 3.1 milligrams a deciliter and above within the prior 8 weeks to screening visit. The regular consumption of alcohol with the intake of greater than 40 grams daily or 280 grams weekly on average for women, and greater than 60 grams daily or greater than 420 grams weekly on average for men for 6 months or more with less than 8 weeks of abstinence before onset of jaundice. There have been a couple kind of cheat sheets for drink counts out there. I will send you the one that we used in TREAT. We are using the standard 14 grams for a standard drink. So just to make sure that we're all using the same guidelines. The AST value should be greater than 50, so 51 and up. AST and ALT ratio is greater than 1.5, and both values are less than 400, and or an histological evidence of alcoholic hepatitis.
Can I ask a question? Oh.
Yes.
This is Amy from Mayo.
Hi, Amy from Mayo.
Hi. When you say and or, what does the or, like, what if their AST is 45, but they have histological evidence of AH? Is that where the or comes in? That part confuses me a little bit.
I would think that that's how I would interpret it. I would definitely just.
Or like, I mean, A, B, C, and D, if they don't have one of those, but they do have evidence of AH, do they still qualify?
I think that is an excellent question. I have asked that myself.
You have?
I don't, yeah, but I haven't, received. So it would be wonderful, Amy, if you could email that to us. You could email that question.
Okay.
And I will pass it forward because sometimes, we ask so many questions that it gets kind of lost, but when another voice asks it, it brings it back up again.
Okay.
What I was told is that is something to be discussed with your PI.
And I'm wondering if that's,
yeah.
I just don't want to enroll somebody, obviously, that doesn't qualify, but then I don't want to miss somebody who, if the or.
Yeah, the or throws me off.
Yeah.
So
okay, I will email.
So, yeah, thank you, Amy. Yeah, that's an excellent question.
Okay.
And they did add to that, the paragraph below was changed to make it a little bit softer. The standard of care liver biopsy used to say must be performed. It is may be performed. So, in other words, we didn't want to make it look like we would absolutely be doing a liver biopsy because it's a standard of care. It's not something that's done under the study. And of course, the MELD is 20 to 35 on date of randomization. So our exclusion criteria, so MELD less than 20 or greater than 35, active sepsis, which means positive blood or acidic culture with the systemic inflammatory response syndrome or hemodynamic compromise requiring intravenous pressors to maintain tissue perfusion. We do define SIRS in the protocol. So I know I just had this discussion this morning. A lot of times clinical notes will say SIRS, but please make sure to check what the protocol definition says of what we are defining SIRS as the actual definition. So pneumonia as evidenced by radiological exam, multi-organ failure, a renal failure defined as a GFR of less than 50 milliliters a minute, clinically active C. diff infection, any history of imaging of the liver, ultrasound, CT or MRI showing other causes of jaundice, history of other liver diseases including hepatitis B, hepatitis C, autoimmune hepatitis, Wilson disease, genetic hemochromatosis, alpha-1 antitrypsin deficiency, or a strong suspicion of drug-induced liver injury. Any history of HIV infection, either a positive HIV RNA or on treatment for HIV infection, history or presence of cancer, including hepatocellular carcinoma, other than non-melanoma skin cancer, history of other significant medical problems such as autoimmune diseases, severe asthma, psoriasis, inflammatory bowel disease, etc., that might require any immunosuppressive treatment. Pregnancy or breastfeeding, prior exposure to experimental therapies in the last 3 months, prior exposure to systemic corticosteroid or immunosuppressive therapy for more than 4 days within the previous 30 days, any need for inotropic pressor support to maintain perfusion to critical organs within the prior 48 hours before randomization and initiation of experimental treatment. Any clinically significant pancreatitis, abdominal pain, elevated lipase greater than 3 times the upper limit of normal, and at least edema of pancreas with fat stranding on CT scan. The white blood cell count of greater than 30,000, known allergy or intolerance to therapeutic agents to be tested, inability to voluntarily obtain informed consent from participant or guardian, perceived inability to follow study procedures and comply with protocol, and a platelet count of less than 50,000. Any questions on those? So the screening period is less than or equal to 7 days prior to the randomization visit. During the screening period, participants' eligibility criteria must be confirmed. Patients with a clinical suspicion of sepsis will have an initial run-in period of 48 hours while being screened for eligibility for enrollment. Patients with evidence of sepsis will be excluded from enrollment. So in regards to the clinical suspicion of sepsis, in the 48-hour run-in, almost all of our AH patients are screened for infection upon admittance to the hospital. Per Dr. Gare, this means that it should be at least 48 hours post-admission and after all infection studies have cleared for the patient to be enrolled. Okay, recruitment. So again, men and women of all races, ethnic groups, and socioeconomic status between the ages of 21 and 65 admitted to the hospital with a clinical diagnosis of alcoholic hepatitis. Obviously, the identification of these participants with severe alcoholic hepatitis requires collaboration with the physicians who manage these participants within the hospital and the emergency department. Almost 100% of participants are admitted to hospital based on the severity of their liver disease. Occasionally, they will be seen in freestanding urgent care centers, emergency rooms, or offices. Since the standard of care is to admit these participants for further evaluation to exclude infections as a precipitating cause of decompensating liver disease, they will most be ultimately identified in a hospital setting, and letters will also be sent to referring MDs and referring hospitals. I'm sure all of you at your different sites have your different ways of reaching those people. And we do ask that you please keep a log of the reasons why patients who are pre-screening are not qualifying as potential patients, as well as why patients are declining in participation. This will greatly assist us in evaluating and moving forward with future amendments. So if across the board we are all finding certain things to be the reason that people are not meeting, our even screening potential, it is important that they see that as a group. I don't know that it will change things, but it does help all of us if they have that data. Our compensation is site dependent. You discuss with your site PI what would work best. We happen to be compensating with the Walmart gift card of $50 per visit here at IU. Study visits and procedures, screening visits, signing the informed consent before any trial-related procedures, verifying the inclusion and exclusion criteria, MELD score, medical history, including the alcohol consumption specifics. Now, in this trial, in the RCT trial, the alcohol consumption specifics are not limited to the timeline follow back in the audit. So it can be all sorts of information gained from the medical record, from the patient's immediate family. So we're not limited to only what the patient tells us on the timeline follow back. The vital signs, including the height and weight and concomitant medications that have been taken within 30 days of day 0. A standard 12-lead ECG will be done assessing any liver biopsy samples if applicable, which may have been obtained as part of the standard of care during the current admission. Obtaining the blood samples for the serum chemistry, hematology, hepatic function panel, and coagulation test. Serum pregnancy only at screening. We will during urine after screening. The only questionnaire here would be the timeline follow back, and they should be reminded that fasting for 8 hours is requested if possible. So it is no longer a protocol deviation if they are not fasting. And this is going to be the same for all visits.
Question about the ECG.
Yes.
Does it have to be on the screening visit day?
No. Well, so it has to be plus, equal to 7 days or less from day 0.
7, okay.
So it would have to be screening day or forward.
Say that one more time, I'm sorry. It would have to be what?
It would have to be screening day or forward. So anytime before day 0.
Okay.
Yeah, sorry, there's no, but that's something, again, if you keep running into that where they had a EKG yesterday and we're having to redo all those, that's something we should bring up to them.
Okay, very good.
Yeah, no, thank you.
Yeah, thanks.
So our study identifiers, if you haven't worked with before, it's actually a 5-digit number that, everyone is assigned a number identifier, subsite, and then subject ID will start with your number, and then going forward, so in a linear order between the RCT and the observational, just going in a linear order for each patient. And if you need more labels when you get to the last 5 or 6 patients that you have left, please email UMass right away so they can get those out to you before you run out. So a screen failure, if they sign the consent and they don't meet the eligibility criteria, they will be considered a screen failure. Complete the new subject registration form, complete the eligibility form, and enter it into REDCap. The samples were collected, absolutely keep those and ship them with your regular quarterly shipment to UMass. And this could include the biopsy tissue or if the patient was screen failed after day 0, study labs were drawn. So anything that you have collected for the study, don't discard it just because they were a screen failure. We will still utilize those. For the day 0, the actual date of randomization, again, fasting is just requested and water is not part of that fasting. Going over the medical history, again, including alcohol consumption specifics, the physical exam, vital signs and weight. They will be doing all 3 questionnaires at this visit, assessing and recording any pre-treatment emergent AEs. Again, going over the con meds if there's any changes. A urine pregnancy test if it's greater than 1 day has elapsed since the screening pregnancy test. Confirming the inclusion and exclusion again, and randomizing the participant if they meet the inclusion and exclusion criteria. So additional language that we have incorporated, assessing the MELD score and entering the MELD group as soon as possible into the AlcHepNet REDCap database under the subject profile tab in the enrollment form. Randomization cannot occur without this group assignment. If you're not able to enter the MELD group, so if REDCap is down, please make sure that you provide this information to the pharmacy, and they will follow their procedures for when REDCap is down. Randomization of the participant will be done by the pharmacist only if the participant meets all inclusion and no exclusion criteria. So please send that confirmation of the criteria to the pharmacy with medication request. We actually have 10 included on the next page. It's carrying over here, apologies. Obtaining the blood samples for the BMP, hematology, hep function panel, and coagulation if greater than 1 day has passed since screening. Again, a reminder that you will need the GFR and platelet values with your randomization. Obtain all the biospecimens as outlined in the study table. Dispensing the study medication as an inpatient, it will be going, so I know everybody, how things work at every site is different, but here the medication will be going directly to our inpatient pharmacy from our investigational pharmacy, and they will be dispensing it as long as the patient is in the hospital, but can still instruct our patients not, to swallow the capsule whole and not open it, which would be important, I think, to pass on to the nursing staff, because some patients have trouble swallowing pills and they see a capsule, nursing staff wants to open it. Verbally instructing the patient or caregiver on the subcutaneous injection procedures and providing them with the IRB and approved instruction handout. And again, reminding them that fasting is just requested if possible prior to the next visit. Day 3, again, the physical exam, vital signs, any AEs, any changes to the CONMEDs, assessing the MELD score, obtaining the blood samples as listed in the table, requesting them to fast if possible, dispensing the study medication again, and even if they're inpatient, you will need to redispense. So we have a dispense on day 3 regardless, and you will need to provide the requested information from your pharmacy, including the GFR and platelets, assessing the medication compliance form. So that is also an IRB approved form that we have. If they're inpatient, it's probably listed on your electronic medication record as opposed to the written log. And then if they're outpatient, this is just something for me, I would, if for some reason they're outpatient on day 3, I would bring them in as early as possible just because the safety labs need to result before you can dispense. Day 7, pretty much the same as day 3. You're assessing the medication compliance. Again, now, normally if they're inpatient, this is not a day when we are dispensing medication. But if they're outpatient and the safety labs come back saying we need to adjust the injectable medications with placebo, there is now a as-needed study medication dispense available. So again, outpatient only, since inpatient pharmacy would be adjusting the doses for inpatient, but if they're outpatient, we needed a way to dispense medication if their safety labs required it. So that is in the protocol now. It's probably rarely ever going to happen, but when it does, we wanted to make sure we were all covered for it. Any questions on that? Okay. Day 14, again, going all the medical history. We do have the 3 questionnaires, vital signs, any AEs, changes to medications, the MELD score, all of your blood and biological specimens, and assessing medication compliance. So even if they're inpatient, but they're refusing their medications, as a former inpatient nurse, I know that subcutaneous injections, not patient favorite. So if they're constantly refusing their injections, that's something to assess because it would be a cause for potential discontinuation from the trial. Day 28, something that's changed with this is we do it.
This is Monique, I'm sorry.
Hi.
There's repeated reference to trough levels. Are we going to getting instruction or direction what kind of tubes are needed for that? Because all of the other is you know, the other labs are drawn here as standard of care, but obviously, you know, anakinra trough levels and such are not. So, I mean, how is that going to happen?
Those are our study labs as outlined in the lab manual. So those are actually the tubes that you are drawing as study labs for the visit. We won't know.
Because we don't draw them. They're drawn by phlebotomy here. When these people are inpatients at UMass, they're drawn anytime between, you know, 4 o'clock, 5 o'clock in the morning as standard of care every morning.
Well,
so we would have to get a separate kit to phlebotomy.
Yes.
Okay. To be drawn with their regular clinical labs.
And then
how do is the hospital running these, or you know, then we collect them separately? I'm a little confused as to the logistics of this.
So that is, no, the hospital isn't running these. These are the labs that you are processing and shipping off to UMass.
Right, and we are UMass, so that means.
Oh, sorry.
Sorry. So that means we can't. No drug can be dispensed until the lab tech runs these particular study labs. Is that correct?
No.
Okay, sorry. I guess I'm not getting something.
So you
or they're just study labs for they're not discontinuation criteria or anything. They're just being run as study labs.
Correct.
Okay. All right.
No, I was referring to medication compliance in refusing, in actually refusing.
Oh, no, I was talking because repeatedly these trough levels have come up.
Yeah.
And several slides, trough, anakinra, and you know, whatever else. That's the one that sticks in my head. But that's simply a separate study assessment and does not impact whether or not the patient receives IP that day.
No. These are the they're for specimen banking.
Only. Okay, that makes a big difference.
Okay.
All right, thanks.
Okay. Absolutely. So day 60 and day 90, again, the change to the bigger window, the plus or minus 7 days. Day 90, you are collecting, the saliva is collected at day 0 and day 90. I did inquire as to whether, you know, in the observational trial, the saliva, we had a limited number that we needed to collect for. As of right now, we are collecting saliva in the RCT for everybody until they notify us of something different. But right now, there is no like only 3 patients. It's every patient. So day 0 and day 90, you are collecting the saliva for the specimen banking. So you're assessing some liver scores. All of the things are listed in our source documents that you're entering into REDCap. Okay, and then I don't know if we skipped day 28 was again let me go back to day 28 and just remind you that this is another dispensation day. It would be the remainder of the capsules for study. So day 60 and 90, we went over that we have a plus or minus 7 days. Day 180, again, the window has been changed to plus or minus 7 days from the scheduled visit date. Collecting the medical history, performing a physical examination, vital signs, the 3 questionnaires, any AEs, any changes to their medications, assessing the liver scores, obtaining the blood samples for serum chemistry, hematology, hepatic function panel, and coagulation test. Again, if they've been done as standard of care within the past 7 days, those are fine to use for this visit. So that plus or minus 7 days also applies to lab values. Obtaining biospecimens for the specimen banking as outlined in the schedule of procedures. This is from the study. This is just the table of scheduled procedures. Drug administration and compliance. Day 0, after eligibility is confirmed, they will be randomized. In order to properly randomize and allocate a participant to treatment, the investigator or the designee will be required to register the participant into the REDCap system. A randomization number will be assigned and study dispensing information, for example, the bottle numbers, will be provided. In the unlikely event of a system failure, the randomization will occur outside of REDCap according to the backup emergency plan detailed in the Manual of Operations, which would be the pharmacy manual, not the coordinator one. The IUDCC will maintain at all times a current offline randomization list and will be able to act as the emergency support team until current system is restored to its full capacity. This is where providing that MELD score in addition to the platelets and the GFR to pharmacy would be important. So the coordinator will ensure that participants understand dosing and storage instructions for drug and disposal instructions for the used syringes, making sure to provide and go over the IRB approved subcutaneous injection instructions. Coordinator will also provide all necessary supplies to those being discharged prior to day 14. Including the Sharps container, alcohol wipes, and Band-Aids. I have included at the end of this presentation the Sharps container that I found that is in line with all of the federal regulations. Remember, it has to be opaque. We are not allowed to visualize the syringes. Participant will begin dosing on day 1. So day 0 is randomization with the AM doses of oral and subcutaneous therapy. To avoid potential interference with concomitant medications, we will administer the morning blinded tablet, the zinc or the prednisone, at least 3 hours apart from the other medications the participant will take. This will be, how the pharmacy is scheduling it. Our pharmacy here has scheduled it, so it is given at a time that is outside of that 3 hour, and the pharmacy knows what medications to watch for. So double check with your site IDS to ensure that the scheduling compliance is done. Please provide the IRB approved medication compliance log and instruct participant on how to complete the log. Just reiterate how necessary it is for honest compliance recording. We all know they want to please us or not get in trouble or whatever it is that people kind of think, but I always tell them, if we don't know what you're actually taking, then we can't treat you emergently for anything accurately. So they should be instructed to retain all the study medication, even if empty, and return them to the investigator at the subsequent visit. Per section 2.1.3 of the protocol, the investigator at each site will check for drug interactions between study drugs and other concomitant medications for each participant. So Melissa Allard, who is here with the IU-IDS and has been leading all of this, has given us a list of concomitant medications to check against. And this will also be a form in REDCap to attest that the study team has reviewed the patient's current medications against this list. So every visit, a form in REDCap will list these medications, and you will attest that they are not taking those medications in addition to study meds. So on day 0, they will be receiving 1 bottle of oral therapy and 2 bags of subcutaneous therapy, one with AM pre-filled syringes for 5 days and 1 bag containing PM pre-filled syringes for 5 days. They will all be blinded. They will be overwrapped. Melissa Allard has told me that they're almost impossible to peel off. The over labels are, which is good. so our patients won't be tempted to just kind of peel off the blinding label and take a look underneath. On day 3, they will receive 1 bag of the sub-Q therapy with a 9-day supply, which will all be blinded. And they are to begin that on day 6 through 14. So they'll finish the syringes from day 0 before starting on day 3. And they are to be reminded to place all the used syringes in a Sharps container and return on day 28 if they were outpatient. Day 7, outpatient only. We have a new dispensation listed in the protocol if it's required based on the protocol response to safety labs. Patient will receive new blinded medication from the pharmacy. And on day 28, they will receive 1 bottle of oral therapy, 60-day supply blinded, to begin on day 31 through day 90. Any questions? Any missed dose? They should be instructed to take a missed dose later on the same day as soon as they remember, but no more than 6 hours past normal dosing time for the injectable medications. We don't want them doubling up because they missed a dose. And again, relating to the missed doses, they should not take the missed dose on the subsequent day. In other words, don't take more than 1 dose in a day. If a dose is missed, the participant should make note of this on the given medication compliance log, and the continued trial eligibility should be assessed based on the participant's compliance with the study medication dosing and clinic visits. Unblinding. So the non-emergency unblinding is discussed in detail in the protocol. We're only going over the emergency unblinding here. So if there were a medical emergency that necessitates unblinding, the site investigator will contact Dr. Garay to discuss the rationale for unblinding. If there is a difference of opinion as to the unblinding, Dr. Garay will defer to the site investigator, who retains the final right to see the unblinding. And the site investigator will then communicate with the DCCIU about the decision to unblind the participant, and then the DCCIU will unblind the participant by interacting directly with the site investigator. So, rules for unblinding participants for leukocytosis and concerns for infection and sepsis. So if the participant develops leukocytosis of greater than 30,000, that 10.9 I don't think is correct. The clinical care team, but it's 30,000. The clinical care team may request unblinding if the team believes that knowing the treatment would impact care decisions, such as starting antibiotics. If the participant develops hypotension, which would be a systolic blood pressure less than 90 and/or requires transfer to an ICU, the clinical care team may request unblinding if the team believes that knowing the treatment would impact care decisions, such as administration of pressors, fluids, or other supportive therapy. And if the participant develops any other serious adverse event that is, in the opinion of the investigator, probably related to one of the study drugs, the clinical care team may request unblinding if it would impact care decisions. Who is going to be unblind? So each site will have a designated sub-investigator, the clinical care team at the hospital, and the DCC contact. The unblinding procedure will be that each site will designate that sub-investigator who can be contacted if the participant care team has concerns about rising leukocytosis. So that is something very important to pass out to all of your hospitalists, that they have the name and number of that sub-investigator. The contacted sub-investigator will communicate with the IUDCC to unblind the participant, then inform participant care team of the study drug participant is receiving. The IUDCC will build into this database system and keep track of unblinded participants. The decision to begin antibiotics for possible infection is left to the judgment of the clinical care team. Any questions on that? Drug holding and stopping. The drug holding rules for day 0 to 30. If the following is met, the drug should be held for 3 days. Either documented infection, pneumonia defined as new infiltrate by a chest x-ray or CT scan, positive cultures for blood and ascites for bacteria or fungus, positive fungal cultures only in urine, greater than 50,000. They did not want to include bacteria since it's so common. A central nervous system infection defined as a positive culture of white blood cells greater than 5 and cerebral spinal fluid. Severe soft tissue or bone infections, including clinical diagnosis of cellulitis. So here's that SIRS definition is the other reason for holding drug. Defined as 2 or more abnormalities in temperature, increased heart rate, respiration, or white blood cell count with increase in SOFA score greater than equal to 2 points. Participants will be reassessed on the 3rd day to determine if the study drugs could be resumed or should be stopped. So they'll be reassessed on the 3rd day of the study drugs hold. If the infection clears and participant stabilizes, study drugs will be resumed. For participants with documented infection, if the infection is responsive to antibiotics and participant is stabilized or improved, study drugs may be resumed at the discretion of the clinical care team. If there is no improvement after 3 days, study drugs will be stopped. For participants meeting only SOFA criteria for stopping, if the cultures of urine, blood, ascites, stool are negative and the chest x-ray is unchanged, study drugs may be resumed at the discretion again of the clinical care team. If the participant has a second hold of study drugs due to infection or SIRS criteria, study drugs will be stopped. And the Lille score will not be used as a criterion for stopping study drug since the study will be blinded. Drug stopping rules, day 0 to 30, no improvement or stabilization after holding study drugs for 3 days. Second hold of study drugs due to infection or SIRS criteria, development of severe leukocytosis defined as greater than equal to 100,000. And again, the Lille score is not used for stopping criterion. Treatment, holding, and stopping rules for DILI. If the MELD increases by 5 from baseline or the child score increases by 3 points from baseline, plus a greater than 3-fold increase in the ALT from baseline on 2 consecutive occasions, if there is a competing etiology and DILI can be excluded, study drug can be resumed within 3 to 4 days. If DILI cannot be excluded, the study drug will be permanently discontinued. Additional reasons for study drug discontinuation. They include the unexplained elevation in ALT greater than 5 times baseline or greater than 500, any unexplained elevation in the AlcPhos greater than 3 times baseline or greater than 500. Treatment, holding, and stopping rules for laboratory abnormalities. If the platelet counts drop to less than 50,000, so while they're on the injectable study drugs, the injectable study drugs will be held and resumed when platelet counts is greater than or equal to 50,000. If they have worsening renal function, all patients are randomized to treatment arms while hospitalized. The site's dispensing pharmacy will check the GFR before dispensing the study drugs for the day. This is highlighted and underlined because it's new language. The pharmacy will enter the daily lab values into a REDCap-based decision support form, which will aid the pharmacy by providing guidance on daily dispensation. This REDCap form is in addition to the pharmacy manual of procedures, which also provides guidance on daily dispensation. For the weekend coverage, the GFR and platelet values from the Friday labs may be used to generate this dispensation schedule at some sites. If a subject's GFR drops to less than 30, but is still greater than 20 milliliters a minute, and the subject is in the anakinra group, REDCap will provide instructions for the pharmacy to dose reduce to every other day by providing anakinra placebo 1 day and alternating with the active anakinra the next day. If the GFR drops to less than 20 milliliters a minute, the instructions from REDCap will hold active anakinra and substitute with anakinra placebo.
Okay, we have about 5 minutes left, Jen.
Okay. If the patient is discharged and now outpatient, all injectable drugs will be dose reduced, and injectable drugs will be stopped if the GFR drops to less than 20 milliliters a minute. This is why we have added the day 7, so you can go over the reasons for mandatory trial discontinuation, protocol deviations. The important thing to note, if the deviation affects patient safety, notify IU within 2 working days.
Nope, not here.
Okay. I don't know what that was. Missed visits, if they don't return for follow-up, complete the follow-up as outlined in the MOP. Make sure you record the attempted contacts. Early termination, the important thing to note that we have modified the language that if the patient withdraws the consent, no study procedures may be done after the consent is withdrawn. However, you can ask them if they are willing to complete the day 60 procedures prior to the actual withdrawal of consent. If they're lost to follow-up, you will be able to read these on your own. The AE, SAE reporting has remained the same. It's outlined in the protocol. And nothing else here has changed. This just goes over the remote monitoring, risk-based monitoring, regulatory resources. So we'll send this presentation out. Points of contact, questions, always email any or call any of us. And that's the Sharps container. So I've listed that at the back for your reference. If you find something similar, that's up to site. So that's it.